Welcome to the annual Ben Shine Memorial Lecture. Each year we have a scientific session in Ben's memory. We now have many members who have no idea who Ben Shine was, which is very unfortunate. Ben was one of the early TDOers, and I think what appealed to Ben was the tremendous sense of family and camaraderie that we have as TDOers, and that it was very important to him that we stayed true and faithful to each other, even as we argued like cats and dogs. I think Ben was actually more of a scientist than as a clinician, and I think he'd be very happy today as we examine critically our disease model. Ben loved debate and discussion and always took care to go out of his way to make sure that it was civil and respectful. And I think that we honor him today by continuing that respect and civility that he so embodied and was so important to him. The format today is a little strange. I've arranged for 5 leading endodontists to give a 15-minute presentation on why or why not the evidence for our model and our outcomes assessment is convincing or lacking. Martin and David will give the affirmative argument, and John and I will give our view to the contrary. And then Drs. Lewis and Greenland will rip us all to shreds, or at least try to point us in a direction where we might think a little more clearly about our issues. The 15-minute presentations are just designed to show the major fault lines in our positions and really to show how we are thinking and reasoning about our issues. The order of the presentations was determined by consensus. We're going to start with outcomes assessment with Martin, and then we're going to end with a discussion of disease models with David and I. Then Dr. Lewis and Greenland will take over, and the rest of the day will be spent with them. We have one break this morning for 15 minutes and a lunch from 12:30 to 1:30. And then the afternoon session will be spent completely with our main speakers. You all know Martin. He spent 30 years trying to improve the level of endodontics in this country and to get us to try to understand our outcomes better. He's trained an entire generation of postgraduate students how to think critically about endodontics and how to perform at the highest level of our specialty. He's an author, editor, researcher, postgraduate director, clinician, international lecturer, Grossman Award winner. He's done it all. So, Martin, it's an honor having you here today. Thank you for coming. David Figdor, of course, is well known to everyone in this room. And for those of us on the microbiology side of endodontics, David's an inspirational figure. The deliberate and disciplined way he has approached his research, always being very careful with his words and thoughts and experimental designs. He's a model for what a careful scientist actually should be. I don't think there's another person on the planet who could give a better defense of the conventional disease model than David. And I appreciate greatly his acceptance of coming here today all the way from Australia. He's actually the only endodontist in this room who is both a first-rate scientist and a first-rate clinician. And it's an honor having him here. He's also the only endodontist speaker in the room that doesn't use my software, so it takes a special kind of courage to come into this room and undergo this kind of ordeal. You all know John. From my perspective, John's done more to change endodontics for the good than any person I'm aware of in my career. Certainly no one in endodontics has caused me to examine my beliefs more than John. He's given unselfishly of his time and talent. He's mainly responsible for TDOers having an understanding of cone beam imaging that is light years ahead of our non-TDO colleagues. The meeting today is really because of what John has done in his advocacy of minimally invasive endodontics. And he was really the first person to think about this carefully. And he developed the conceptual understanding of really why we've had such a blockage in recognizing what seems so obvious to many of us now. I'm the last endodontist speaking, and most of you know me for better or worse. I'm an endodontist in San Diego, California. I have the distinction of being surrounded by incredible people, incredible friends, incredible teams, and an incredible family. You all know Roger Lewis. Roger's just finding out how often his videos have been played on TDO, so he's trying to remember what he said 3 years ago. He's one of the foremost authorities on adaptive clinical design, and he has a unique ability to make complex statistical concepts intelligible to clinicians. There are very few instances in life where an entire specialty has a moment of clarity, and we had one of those moments a couple years ago. And I thought I would just play it for you. For those who haven't seen it or aren't on TDO chat, this was a moment of complete clarity in a specialty. I hope you can hear it.
Okay, how about for this? Why is it that you guys have studies that look at this apical radiographic changes as an outcome? Okay, so it's a proxy for success, it's correlated with pain.
And by that stage, we change our whole profession. And that would be the ideal.
So who are we treating? You have to know that this psychological need to have personal effectiveness, independent of what's perceived by the patient, is shared by all healthcare professions, okay? I can come up with lots of examples where in my particular specialty, we did the same thing for years, and some people only gave up the outcome measures they cared about when they died. The physician died, okay? Okay.
Do you remember that? Not at all. Well, it changed the conversation in our group tremendously. Sander Greenland is one of the world's foremost epidemiologists, if not the foremost epidemiologist in the world. He's devoted his entire career to trying to understand the nature of influence, causality, and the deeper philosophical and complex mathematical issues which surround these subjects. If you've read any of his papers or even followed his discussion with Gelman on Gelman's blog on p-values and priors, you know the deep level that he operates at. He's promised me today he can dumb it down to our level so that we can understand it. As endodontists, we don't often get an opportunity of mixing with persons of this caliber very often. So Dr. Greenland, it's an honor having you here. Are you here? He's not here yet. Okay. So before we begin, I'd like to play a small snippet from Dr. Goodman's presentation here in 2012.
You know, ultimately this takes, you know, a long time and immersion and careful thinking.
So what is our problem? We're clinicians. We don't have the luxury of immersion. So what can we do about that? Well, what I've tried to do on TDO, okay, maybe we can't really immerse ourselves in this, in the way that is needed to really have careful thinking, but maybe the least we can do is expose ourselves to people who have really immersed themselves and whose life is characterized by careful thinking. So that's basically what the purpose of these meetings are, to expose everyone to people who have made it their life study to study these issues in detail.
It's a formula for how you respond to evidence. So in a sense, this is a formula for science. This is saying you can start wherever you want. You know, start wherever you want. You can say this is a cockamamie theory, this is a probable theory, but you gotta respond to data in a coherent way. And you can show theoretically, formulaically, and that if you don't obey this rule, that you will always end up being caught in incoherent beliefs. That you will say things like, this treatment is better than that treatment, A is better than B, and B is better than C, and C is better than A. Or you could simultaneously come to the conclusion that C is better than A and A is better than C. That is, the probabilities of being one better than the other adds up to more than one. I mean, all sorts of crazy stuff. So if you don't, you can show that if you don't modify your beliefs in this way, any other way of modifying your beliefs ends up with crazy beliefs.
Why does that ring in our ears, ending up with crazy beliefs? So today we're going to examine whether there's any evidence that we entertain incoherent thoughts. Okay. So we're out of order here a little bit, but so we want to start with David. Okay. We're going to start with David Figger. He's going to review his opinion on our disease model. Come on up, David.
Thank you very much, Gary, for inviting me to speak today. By the time we've completed this discussion today, more than 60,000 endodontic treatments will have been carried out across the United States today. Yet the amazing thing is that for such a prevalent disease, we have remarkably limited knowledge of the microbe host disease process for apical periodontitis. So when Gary asked me to speak about our disease model in endodontics, I thought, sure, understanding microbial etiology and pathogenesis has driven my passion and curiosity for the last 30 years. So after I agreed, Gary then said, there's just one little thing. Can you do it in 15 minutes? Right. That's like asking me to summarise the entire field of microbial pathogenesis and condense it down into a micron. But let's give it a go. So the subject is our disease model, what we know and what we have yet to learn. And my purpose is to give an ultra-brief synopsis of the microbial pathogenesis of apical periodontitis. And I want to start by making 3 points. The first is that microbes are everywhere. So they're in the environment, they're on our skin, they're in the oral cavity, they're everywhere. But not every site has pathology. So it depends on that microbe-host interaction as to whether pathology will occur. And the third point I want to make is that caries and periodontal disease differ in that there's already a site where there's a microbial population and there's an ecological shift in that population and the host response that results in a disease process. And that's different from apical periodontitis, which is essentially a sterile field. You have pulp necrosis, infection of the root canal space, and ultimately the periapical tissues. So in 15 minutes, or the remaining 14 minutes, what I'm going to show you are 3 main things. The first is, what is our disease model? The second is the conceptual development in the literature over the last 135 years. And thirdly, what have we yet to learn? I want to open up that door to many, many things that we need to still know. So let's start with, what is our disease model? And obviously, in 5 minutes, it's a really broad outline. So the first thing to say is that we know from both animal and human studies that microorganisms are essential for the development of apical periodontitis, with rare exceptions such as trauma. The second thing to say is that no one species is responsible. So in most untreated root canal infections, they're polymicrobial, consisting of a dozen or more species located inside the root canal space. The third thing is that there are ecological, nutritional and environmental factors that drive the course of the infection. So it's the habitat that selects for the microorganisms that successfully colonise that site. Now, from the seminal paper published by Ramachandran Nair in 1987, we know that microbes don't occupy the root canal space as planktonic cells, but they occupy the root canal space in communities. And you all know that Costerton described most living microorganisms as growing in biofilms, as best exemplified by the slime on rocks that are growing in a running river stream. But I think in the root canal, a more apt description of the community growth pattern is that they grow in aggregates. So those aggregates sometimes live as single colonies, as you can see at the top of the screen, and sometimes they grow in microbial aggregate communities. So that's their pattern of microbial growth. It's important to recognise that infection of the root canal space is not fixed. So it's a dynamic process that changes over a period of time, and there are microbial population shifts over that period of time depending on basically on the nutrition available inside the root canal space, starting with sugars from the oral cavity through to proteins and peptides as the microorganisms digest what's available in the pulp space. It's frequently overlooked, but cementum is a crucial barrier for the host defence. The reason why we see periapical bone loss here on the lateral surface of the tooth is because there's an opening from the infected root canal space to the host. And the reason why we don't see bone loss where you've got the highlighted green arrows is because of the intactness of the cementum at that site. So when the cementum is present, the host is essentially protected from the invasion by the microbes. So cementum is crucial for all of endodontic treatment and for the pathogenesis, and without it, we'd all be in real trouble. During treatment, we know that some microbes have the capacity to survive that treatment better than other species. So, for example, gram-positive species generally have a more favourable capacity for enduring the altered nutritional environment within the root canal space. So there are certain species that are favoured as a result of that changed habitat within the root canal space. The last point I shall make here is that for us to see clinical or radiographic signs of periapical infection, there must be access between the infection in the root canal space and the host periapical tissues. And when that access is present, then there's the possibility for microbes to interact with the host, resulting in periapical inflammation. So the next area I want to come to is the conceptual development in the literature over the last 135 years. And as you can imagine, it's impossible to cover that in the space of 5 minutes. But perhaps I can best serve you by outlining landmark papers that have been necessary for the conceptual development of our disease model over the last 135 years. And I hope that the authors that I don't include in this will forgive me for not mentioning their contributions. So it really all began with Robert Koch in the 1880s, and he was a German scientist, and over the space of about 5 or 6 years he discovered the bacteria that were responsible for anthrax, tuberculosis and cholera. And whilst his findings in some respects are incomplete, I should point out that all of mankind has benefited from the discoveries he made with the tools available at that time. Now, Miller was an American working in Robert Koch's laboratory at that time, and even though it was 135 years ago, he showed already at that time the gap between what was cultivable on the plate, using their methodology at that time, and what could be seen under the microscope, looking at the microorganisms in that particular sample. So already at that time, that knowledge was there that there's a difference between what is cultivable and what is actually present as seen by microscopy. So things took a turn for the worse with the percolation idea in the 1930s, and that really took us off track for about 30 years with the idea of Rickett and Dixon in their idea that stagnation of fluids inside the root canal space percolate back and cause periapical inflammation. But things started to come back on track in the 50s and the 60s. The landmark work of Ocker-Moller, which demonstrated a way that we had the methodology to recover bacterial samples from the root canal space in an authentic way, exclude contamination by local infection, and also get those samples to the laboratory for accurate processing. So that was his main contribution in 1966. And then came the era, I think, of modern endodontic bacteriology, and I just mentioned three main papers. There was, of course, the Kakahashi, Stanley and Fitzgerald model in rats, showing the importance of bacteria as the etiological agent for apical periodontitis, the work of Göran Sundquist in humans, and the work of Moller and Fabricius and others in monkey teeth, also demonstrating the same thing. And then in the 1980s, we had the work of Anders Bistrom and Göran Sundquist that that divided up the components of our treatment, the mechanical instrumentation, the irrigation and the dressing, and looked at the efficacy of microbial control during the treatment. And of course, I mentioned the landmark work of Ramachandran Nair showing how those bacteria and the microorganisms are living in the space. I mean, prior to that, we really had little information. You might have assumed that they were planktonic cells floating about in the root canal space, but he showed that community growth pattern at that time. And then there was the work of Ulf Sjögren, myself, Ramachandran Nair and Göran Sundquist in the 1990s, looking at many of the reasons for failure of endodontic treatment, at both the microbiology as well as some of the other factors that are involved in unsuccessful treatment. And then in the 2000s, we saw the work, the molecular era, and that was mainly led by Jose Sequeira and Isabel Rocard, using predominantly in the early years PCR technology to identify and speciate many of the species within the root canal space. And that showed perhaps an increasing diversity and range of species than we'd seen by, back then, advanced culture methods. But also in the 2000s, we saw some of the shortcomings in all of these areas. So we began to realise that there are some limitations in three main areas. So one is in the sampling. So when you place a paper point inside the root canal space to pick up the bacteria, you're picking up many of the species, but you may miss some in that process. And that also applies to the file technique, where you take material out with a file. So there are some problematic and methodological limitations in terms of the sampling. But also we began to realise that culture, albeit advanced for that period 20 years ago, there were many species that were not yet cultivable, as we saw with the advances in molecular identification. But then also in the molecular era, we've come to understand that because of the unique binding capacity of DNA to the hydroxyapatite in dentine, and for that matter in bone, that binds DNA to the dentin, and therefore that may mean that the sampling that you're doing is not authentic sampling from the root canal space. So in other words, that not all of the species that are detected with the molecular techniques can be attributable to the root canal infection. And then of course we're here at the present, which is now in the future, 2015, and there are many, many open questions to resolve. And that brings me to the third point I want to make here. And that is what's missing and what have we yet to learn. And so there are many gaps in our knowledge, but let me give you a few areas of particular interest to me. So one is about pathogenesis. We know that the involvement of microorganisms in the Carious process. We know about the involvement of microorganisms in induction of periapical inflammation, but we've got very little knowledge of how the bacteria start in the crown of the tooth in caries and end up down in the apical area. We've got almost no knowledge in that area. And how do the microbes get there? And I think that's an important question that potentially has treatment possibilities. A second thing is measurement, and we need better ways of identifying and quantifying the types and numbers of the microbial flora, and where are they? Particularly at the apical part of the root, which is the area that we're most interested in as part of the disease process. So using culture, histology and molecular methods, we must answer the questions of what are there, how many and how few are there, but also where are they? Where do the bacteria and the microbes need to be to induce periapical inflammation? Because presumably if they're in a coronal part of the root canal space, they may not induce periapical inflammation. Another question is treatment efficacy, and how and which microorganisms survive treatment. So how do they do so? Which ones? Where are they? What is the fate of the microbes that survive? We know that in many, many cases, perhaps the majority of cases, microorganisms will survive our treatment procedure. But what is the fate of those microorganisms over a period of time? We've got very limited information about that. And most importantly, how do we access those bacteria that do survive? And there's a lot of attention to different types of microbicidal agents, but I see it as a problem of access of the microbicidal agents rather than which agents to use. In many cases, microbes will survive, but we've got very limited knowledge of how they will influence the outcome of the disease and whether it's going to be favourable or not. So which cases are going to be favourable, which are not going to be favourable. So of the microbes that survive treatment, which ones are going to survive, and when and how are they going to inflame the periapical tissue, and then how does healing occur in those cases? So there are so many open questions. The door is open to many, many questions, and I'm sure that the other speakers today will raise many more. But some other questions are how do we differentiate between what's new infection and what is persistent infection? We've got no means for determining between the two. How can we get more predictability in our treatment outcomes, knowing that in many cases small pockets and small amounts of bacteria will survive the treatment, but which cases are going to continue to inflame the periapical tissue? And one of the most common reasons, I think, for failed teeth, that is cracks, has had almost no microbiological analysis. So to summarise, there are three main points I've covered today. I've spoken about what we know, the conceptual development in the literature over the last 135 years, and what have we yet to learn. I want to leave you with this last thought. And when I first started, the key thing that drew me to endodontics is that I saw the field as being ripe for research. And I share Gary's curiosity and his passion for discovery and understanding. And it's exciting to me that there are so many interesting questions that are still waiting for full scientific exploration. The field is open. So what we most need now in endodontics are individuals who are curious and ask insightful questions that lead to discovery and advancement. We need young researchers, but we also need experienced mentors, with bright, scientific, curious minds, but also innovative and strategic thinking to map out the future for our specialty. So whilst those 60,000 treatments are done today, it would give me the greatest satisfaction if just one individual in this room here is infused with the passion to be that investigator. Thank you.
Thank you very, very much. It's a great pleasure to be here. I only realized today I was a gold member of TDO, so should have asked for more money, but I'm going to spend a bit of time more on treatment and trying to make the argument that our outcome studies do support this microbiological model, because I realize that what is going to come afterwards is a challenge to the microbiological model. So the question is, do our outcomes support this microbiological model? And I want to make one point before I start, is that it's all very well for us to talk about, I don't know, 70, 80 people. In a healthcare profession, we have to do the best according to available evidence. We don't have to, but then we must not expect the privileges of being part of a healthcare profession. Okay? And also, that means that not everything is perfect, and David has pointed that out, and not everything is black and white. We're talking about the best treatment for the most people. And there will be many, many, many exceptions that a clinician can pull up and say, this disproves your model, therefore your model is wrong. And I disagree with that point of view. It's the model that gives us the best outcome for the most people, and then we adjust it according to new evidence. So endodontic disease in the classical form is apical periodontitis. As David mentioned, it's a cyst or granuloma. We really don't think we care whether it is a cyst or a granuloma, because we believe, we believe that most, then I need my glasses, most can heal. And radiographically, it will show as a radiolucency. And of course, I picked a radiolucency that none of us are going to argue, is there a radiolucency or isn't there a radiolucency? Now, this could be today, and this could be tomorrow. Okay? And we are going to treat this acute infection with antibacterial means. Okay, and if I look at that little clip that we saw before, I would say as a healthcare professional, if I had evidence of a carotid closure due to atherosclerosis, I wouldn't give the patient the option of treating because they're not symptomatic and then wait for the stroke. I would try the best possible way that I knew to convince them. Ultimately, it is their decision, of course, but I try the best possible way to convince them to treat that blockage in the carotid artery so that they don't have a stroke. And this is very rare, and it's very lucky for us, but in some ways it's unlucky because then we don't sort of keep in mind what our problem really is. So our idea, as with all healthcare professionals, is to prevent the easy part, vital teeth, or eliminate the difficult part, infected teeth, apical periodontitis, which we believe is our disease. And of course, without losing the tooth, because we have to acknowledge that the best way to treat both marginal periodontitis and apical periodontitis is to extract the tooth. But it's implied in our specialty that we are going to do everything we possibly can to maintain the tooth in the mouth. And a very legitimate question, how best do you do that, etc. Now, if we look at outcome studies, and this represents thousands upon thousands upon thousands of teeth, if you have no apical periodontitis present, implying less infection. Most of these teeth are vital and non-infected, but I'm not going to claim that. I'm going to say that very few of these teeth are infected, or there's a low threshold of infection. The evidence tells us that our outcome in terms of healing this apical periodontitis, radiographically mainly, but also clinically, is extremely good. If we, on the other hand, look at teeth with infection, evidence of apical periodontitis, the treatment outcome is 10 to 15, sometimes 25% lower than when we don't have infection. These outcome studies tell me that infection is a problem, and they tell me that our treatment rationale and our treatment protocol should be directed at improving infection control. And if theoretically we could get to that very low microbial count of vital teeth, we should, and actually with new evidence, we know we can get over 90% success in terms of eliminating the disease, even in teeth with apical periodontitis, if we focus on antibacterial methods alone. Now, David mentioned the problems with culturing, and I agree with them completely. These were culture methods from 1980, 1985. What in science lasts 40 years? But that's the only thing we have that correlates to success. And I know these are, maybe you're picking up planktonic bacteria, and we now talk about biofilm, but we are instrumenting and breaking up certain amounts of biofilm. I know the studies have problems, but irrefutable in my view is that if you have no culturable bacteria, and remember, I'm not saying no bacteria, I'm saying the degree or the threshold is so low that our techniques, as bad as they are, cannot pick up those bacteria, we get a very good success rate for primary endodontics. Don't worry about the retreatment for this talk, if you will. On the other hand, if there are more bacteria, more microbes, not all the microbes, I don't even know if they're the important microbes, but if we have more microbes, we have less success. Okay, and you all probably know the Sjogren study where they did one-step endo and they took culturing. I think, David, you were on that study, right? So it's no good. They did culturing at the time of obturation, and then 5 years later, as only the Scandinavians can do, they came back and correlated success to culturing methods, and the ones with less microbes or non-culturable bacteria had 94% success, and the ones where you could culture bacteria had 68% success. Now, interesting in the study is why, if you can culture bacteria, do you have 68% success? That's an academic interest, and that is very, very nice to look at academically. But as a clinician, we have to make the conclusion that we need to focus on disinfection and a better disinfection. So one of the points I want to make today is the difference between an academic question and a clinical recommendation. So less microbes means better healing, means a better prognosis. And endodontics, in my view, is microbial control. And progress of our field is going to depend on more efficient control of microbes. Sterilization of the root canal will result in success whatever the detector method. So I don't care if you're doing a periapical radiograph, which is our standard to this point, and you can make a very legitimate point that CBCT would be better and would show a lower success rate. Correct. And histology would be even better and would show a lower success rate. Correct. But if we sterilize the root canal, we're not able to do that at the moment. But if we sterilize the root canal, all three of those detector methods would show no disease based on our belief. So the focus is not to throw out the baby with the bathwater and say, oh, you're using a periapical radiograph, therefore nothing's legitimate, let's change the whole model. The focus must be, let's get closer to sterilization. And let's focus on better methods of getting less microbes. Now here is, unfortunately, what's going to happen to those 60,000 root canals that are done today. And that's if you do a cross-sectional study of endodontic treatment done in private practice in communities all over the world, the success rate is nowhere close to the university-based studies. I would say generally it's 50%. 50% is chance, right? But very interestingly in these studies, if you look at the quality of the endo, it's usually done very poorly. And if you select out good endodontics with a good coronal restoration, even in these studies, then the success rate is in the high 80s, low 90s. So again, our problem is not to change the model, in my view. Our problem is changing the quality of endodontics as we do it. Now, what is an adequate endodontic treatment? I'm not going to spend too much time because I'm under tremendous time pressure, as you may understand. But generally speaking, long is bad. 0 to 2 millimeters is optimal, and more than 2 millimeters is less than optimal. Okay? Again, in my view, supporting the microbiological model. The level of instrumentation and obturation of the root canal had a significant incidence of prognosis. Shugal, vital cases, for every millimeter loss in working length, the odds of failure increase approximately 14% after the last 2 millimeters. So this makes absolute sense to me if you consider that microbes are our problem. So vital case, you should be 1.2 millimeters away from the radiographic apex, a necrotic case, 0.5 millimeters closer to the radiographic apex, representing, in my view, apical resorption of cementum and not a change in position of where you instrument to. But short is better, and if you look at the literature, as bad as it is, that is one of the most consistent findings in our literature. Short is better than long. Now, I presented these two cases to our other speakers, so I'm going to just present the outcomes. A prospective study, factors influencing success, and this is also very consistent in our literature. A preoperative absence of periapical lesion results in better success. Turn that around. If you have a lesion, in other words, infection before you start, your success rate is decreased. Presence of a lesion smaller results in a better success. Absence of a sinus tract, again, infection. Presence of satisfactory coronal restoration. These are 4 critical factors, according to that paper, which are necessary for optimal success. And I'll go over this one because I want to get to this paper. Now, the prevalence, this is a study just completed at Penn, submitted for publication, and the author, primary author, did not want me to give her name because she is on TDO chat and she doesn't want to be ostracized. So that's something you people have to take into consideration. So, prevalence of apical periodontitis in endodontically treated premolars and molars with missed untreated canals, a CBCT study. Missing a canal makes 4.3 times more likelihood to develop a lesion. The prevalence of apical lesion in teeth with missed canals was 82.8%. All lesions were around the root with a missed canal. Okay? So this actually study was done in reaction to the New Jersey meeting that we had previously. And that's how studies have to be done. You have to have a research question based on something you believe or disbelieve, and then do a study to evaluate whether that is true or not. So I'm just going to finish very quickly again, because I don't have time. Functional success, and that means basically we need the tooth in the mouth. And I would prefer to have a tooth in the mouth with apical periodontitis than a tooth that is fractured without apical periodontitis, obviously, right? So we need both biologic success, or the disappearance of apical periodontitis, and also functional success. And this has been studied, generally speaking, in reaction to the threat that we feel from implants. But I'm going to use the studies just to talk about endodontic treatment. So in this meta-analysis of single unit restorations, survival, restoration was a requirement, and follow-up for more than a year. And the endodontic treated teeth did extremely well. If you look here, representing over 3 million cases, the endodontic treated teeth survived extremely well. So in my view, again, this is not one of our major problems. And if it ain't broke, don't fix it. Right? So I think if, in my view, we've got enough problems in microbial control that we should focus on microbial control, and certainly not at the expense of maintaining a viable tooth. So basically, the role of the dentist is to restore immediately after the root canal treatment with a permanent crown in the posterior region if possible, and should provide at least one contact point. So I'll just go. This is a study by Dan Kaplan. He was with me at UNC. And endodontic treated teeth not crowned after obturation were lost at a 6 times greater rate than teeth crowned after obturation. That's in the 3% that were lost. So let's not misjudge this. This is not 6 times total. It's in the small percentage that were lost. It was 6 times greater than the rate of crown teeth. And if you then go to further studies, if a tooth does not have a mesial or distal contact, in other words, is a freestanding tooth without any teeth or balance, there's a 12 times greater chance that that tooth will be lost. So our solution is better root canal procedures. And I thought I'd just end on this just to irritate a few people. And not smaller access cavities. Thank you very much.
Why am I up here talking about outcomes and evidence? The story starts at Iowa. Well, kinda. It starts a little bit before that. I got lucky even getting into dental school. I got lucky getting to work in Professor Apkarian's lab in the 1980s. Really, I got lucky having the right parents. Thanks, Dad. I had a strong math background for a dentist and had written software for over a decade. It's 1986, and I'm a freshman at UCSF, and I'm getting a job at the nursing department working data entry. I end up writing a piece of software and get exposed to the project where they're doing causal model. Professor Greenland, do you know what those are? The interest in computers naturally parlayed into an interest in digital imaging and digital radiography, which was commercially introduced in 1987. I wrote software to do digital subtraction radiography, and among other things, we did an abstract presentation at the RSNA in 1990. Thus, I was fortunate to be able to join the RSNA, the Radiological Society of North America, 25 years ago. This was simply a lucky break of having the right background, going to the right university, and finding the right people at the right time. It was just luck. That luck continued when I went to Iowa, which with the University of Chicago were really at the center of PACS and imaging research. It was there that I met Professors Chang and Birbaum. I ended up doing my master's thesis on digital imaging, writing the software for it, and most importantly, getting exposed to world-class people in that domain. Perhaps even more importantly, getting exposed to world-class people, period. So the reason I'm telling you this is that there's maybe some sort of misconception. I'm not smarter than any of you guys. I just got exposed to this very early on in my career, and it was just luck. That's it. So that chapter in my life closed, but the luck continued. I go to San Francisco and practice with Eric Herbranson in the mid-1990s. Thank you, Eric. I'm still an AAE member, so I'm getting the JOE and seeing these kinds of articles. And I'm having trouble with them already. Hidden orifice obscured by an overhang. You're using a microscope, right? Tilt the mirror. I'm an RSNA member as well, so I'm getting that publication and related articles like this Elmore paper that Professor Birbaum described as causing quite a furor in the readership. I don't know Professor Greenland yet, but he's writing about sensitivity analysis 20 years ago. Who has seen a sensitivity analysis in our literature? What is sensitivity analysis? Anyone heard of it? We're culturing and inferring that absence of evidence of growth is the same as bacteria-free. The microbiological community is talking about the great plate count anomaly. Why are we culturing anyway? Everybody knows why. Everybody knows this paper. Why isn't there raging AP here? The paper says, without exception. The specialty sits on this paper and the following chain of logic. The prevailing treat model, Kakahashi's work convincingly established the role of bacterial infection in atypical periodontitis. If bacteria, then AP. This work also demonstrated the important fact that in the absence of infection, healing and repair is predictable. Not bacteria, then not AP. So a great deal of our work has been directed at getting out and keeping out the bugs. A very common approach to evaluate the efficacy of various treatment strategies or intervention parameters in reducing or eliminating microbes has been culturing. This goes on for years, this focus on removing and killing the bugs. I went to Iowa, I bought into it. Let's take a look at the logic of these models.
Now, here is another way that associative memory works. Is the following argument valid? And here is the argument. All roses are flowers. Some flowers fade quickly. Therefore, some roses fade quickly.
Is the logic valid? If bacteria, then AP.
The argument is not valid. It's entirely possible that some flowers fade quickly, but none of them are roses. Now, a vast majority of undergraduates consider this valid.
It would seem that a vast majority of endodontic researchers consider this valid as well. People are still culturing, and we're still citing culturing work. Absence of evidence is not the same thing as evidence of absence. It is certainly not bacteria-free. Are these chains of logic valid?
The argument is not valid.
Oops. This is one form of what we've casually referred to on TDO as inversion of the conditional. That is, the basic thinking in the specialty. I see this, but I'm just in practice like most of you. I don't have an academic appointment or a PhD. Academia has told us, the clinicians, your clinical experience doesn't amount to squat. It's the lowest form of evidence. No worries. Rotary Nitai is coming out, and Eric and I are geeking out on weekends developing teaching materials at Talking Shop. It's the late 1990s, and the material is pretty much clean-shaped pack, although I had been thinking about access in light of what we could do with the microscope. What I was sure of is that these kinds of mental models and the drawings and instruments and techniques as shown here in Ingle don't work. And I was a contributor to this edition, but I was still a recent grad, and everybody knew me as the computer guy. I was also still trapped by my own training and dogma on shaping and apical size here in 1997, calling this a bad thermophil lower molar, mistaking the process outcome for the outcome. So a decade's passed now since the Trophy RVG system was introduced while I was in dental school, and digital radiography has captured a lot of attention like CBC2 is doing right now. I'm basically a fixture at the AAE those years speaking on digital imaging and digital radiography, so I'm reading the work in the dental domain, but as an RSNA member, I'm also reading what's going on in medical radiology. So I'm seeing, well...
In the last talk, I focused it on particular areas that looking at your literature, I see as difficult spots.
Don't sugarcoat it for Professor Birbaum. So in addition to the difficult spots in the radiology literature where I had some experience, I was also seeing difficult spots more broadly in all our outcome-based work. Take this paper, for instance, essentially all dental citations. They plug in the numbers to software they got from Charlie Metz and generate some ROC curves to report instead of just sensitivity and specificity. Now, they look like the smart guys, but they don't understand that you simply can't compute the area under the curve of the individual observers and average them, as this violates the independence assumption. Oops.
Well, there's a lot to be said for the strategy of finding the smart guy.
Thank you,
Okay.
Roger. What I think has happened is some of the smart guys have created some very powerful software that only require that you know how to work it, not know how it works. There is an important distinction and illusion of understanding, mistaking knowing how it works for knowing how to work it. Knowing how to work it for knowing how it works. Knowing how to work a root canal is different than knowing how a root canal works. Mistaking how to work a CBCT for how a CBCT works. I was the stats guy because I could plug stuff into SPSS. I had no idea what I was doing. So it's 2005 now, and I'm on TDO, and people are starting to talk about the TDO outcome study. And I see a paper like this come out that has the issues with culturing as an unvalidated proxy to infer long-term outcome predicated on a treatment model that rests on an invalid form of logic. We'll skip that part. Roughly, first, does the study say what the authors say it says? Threat stability. Are their conclusions justified based on the work? Second, do the results apply to my patients? Can we take that study to practice? So I'm seeing many of these threats to validity, issues with the proposed design of the TDO outcome study, but nobody understood what I was saying, didn't believe me, or both. Those that remember when this TDO study was getting going and I wouldn't participate, everyone was baffled. I was a bomb thrower who couldn't read radiographs. It's not that I know how to do clinical research or to design a clinical trial. I don't. That's what clinical trialists and guys like Roger Lewis do. What I did know, however, was how not to do it and what was the purpose of clinical research. Dr. Lewis, what's the purpose of clinical research? Don't worry, I got you.
This is critically important because the purpose of the clinical research is to inform the decision of what your strategy is for treating the patient.
The intention to treat principle. Here, over 10% of the patients failed the second visit. Part of the potential effectiveness for choosing multi-visit therapy hinges on the patients coming back for subsequent visits. That's part of the real effectiveness or lack thereof of that strategy. So while the remaining 87% of the patients may have had the potential for improved outcome from the two-visit strategy, I think we can say 13% of them definitely had worse outcomes. We won't have time to go into how the analysis effectively counted the NC patients as a zero sample count, or they computed means and ran paired t-tests. That would have been topic 4. Missing data. So when someone calls what Clark and I write as opinion pieces, well, we know it's an opinion piece. We're not masquerading it as science with t-tests and p-values. Logic, the epidemiology paper. Look into the insurance database for teeth with endodontic claim codes, then follow them to look for retreatment codes, surgery codes, extraction codes to estimate the endodontic success, survival, retention, whatever. What's wrong with this picture? So here's the model. If intervention, then failure. Not intervention, then not failure equals retention. Where have we seen this before? This is denying the antecedent. Glenn, do you follow an insurance claim for every tooth you extract? Scott, do you file an insurance claim for every tooth you extract? No. Kevin Mullen, do you? No. What about the hundreds of teeth that are extracted that never had a claim? Is the argument valid?
The argument is not valid.
These kinds of papers provide no information on baseline predictors of risk for outcome, risk stratification, treatment strategies, intervention parameters, treatment objectives, process outcomes, really nothing that informs decision making. They actually misinform survival or retention or whatever one wants to call it, because evidence of subsequent intervention is some evidence for, but not the same thing as retention, and it's certainly not success. We're not going to get to outcome measures. Counting death as a good outcome. That jumped ahead. I'm sorry. We're not going to get to outcome measures, counting death as a good outcome, imputation of 0, or sensitivity analysis. bumped it. But what I can tell you is the academic evidential base is a house of cards. If the evidence isn't in the literature, where is the evidence? It's been right in front of us this whole time, but our knowledge of what's required for outcome has blocked the actual observations.
You have to assume that System 1 is largely indifferent to the quality and amount of evidence. It is bound more by the coherence of the story than by the evidence behind it. System 1, the associative system, is also wonderful at the speed with which it updates its knowledge. When there is no violation of existing preconceptions, when there is no belief system, this is the way we update our knowledge of the world. When what we learn doesn't conflict with existing beliefs. When what we learn does conflict with existing beliefs, we don't accept it. We reject it, we don't believe it.
I think someone once said, I'm not interested in those cases. Those are the very cases we need to be interested in. It's time for us clinicians to take this specialty back. Thank you.
You only have to endure 15 more minutes of this, and then we'll have Roger. So this exercise of 15-minute appointments or lectures is a form of inhuman punishment. But it was really done for, the only reason I did it, because you're all familiar with these arguments in the papers, and we've rehashed this over and over again on TDO Chat. It was really to give Roger and Dr. Greenland's kind of a sense of how we're thinking. I practiced my presentation and could never do it in 15 minutes, so I actually just made a videotape of it, and it is 15 minutes. So I'm gonna just play it, and then we don't have to worry about running over.
The foundation of our specialty is, of course, our disease model, a model we feel has been verified repeatedly over and over again by very careful clinicians and researchers for over 60 years. Now, much of this
Double-click the title bar, Gary. Just double-click the title bar.
No? Let me just clone it. How's that?
This research is the result of incredible commitment by researchers, and I don't want to disparage it in any way. It's the conclusions from the research and the inferences we draw from this work that is where the problem is. In the language of logical inference, the proper way to frame this is microorganisms are necessary to be present for the development of apical periodontitis. But it does not follow that microorganisms are the necessary and sufficient factor in apical periodontitis, because many cases have large numbers of microorganisms present, yet show evidence suggestive of healing or at least surviving long term. So our model needs to account for these cases. It needs to give a biologically plausible explanation for how cases like this can actually be successful. If you don't know what is both necessary and sufficient for a disease to occur, then you can't even begin to claim that you know what the cause of the disease is. So, in my view, we don't actually know what causes apical periodontitis. We only know that microorganisms appear to be necessary for the development of the disease, but we don't know what is necessary and sufficient for the disease. We have very little knowledge of the confounders of this disease. Our model is based solely on idealized counterfactual experiments that fail to consider the complexity of the disease we treat. The only real test of a model is, can it explain what we observe? It would also be advantageous to have the model have some biologic plausibility in its mechanism. The model must give an account for how cases such as this can be successful. To claim that such cases are successful because we have reduced the bioburden, or starved the bacteria to death, or reduced the substrate below a certain significant level, or my favorite, sealed the canal so bacteria can't get out, these explanations strain credulity and simply aren't plausible given what we know about our ability to address the anatomy. Our model has to explain the success on cases like this of John's, where clearly all substrate has not been removed, where the irrigants can't possibly have had much effect at the terminus, and where at most you have a single cone obturation. Yet these can be very, very successful cases. So hopefully we have some agreement that our model does not explain fully what we all observe. In other words, there's a bypass. And I think we should recognize that we come to our task with significant bias from our training, and that bias may trick us into thinking we know something when we really don't. So why can't our model explain these things? Well, the planktonic disease model, the Kochian model, is essentially different from the biofilm microbial disease model. One is continually supplying organisms to the host. The other, only in its dispersal phase is it shedding organisms. And planktonic disease is monospecies and monoclonal. Biofilm disease is polymicrobial and polyclonal. In planktonic disease, one microorganism. In biofilm disease, there are many species and a very wide distribution of disease states. And as Garth Ehrlich has taught us, biofilms are phenotypically and genotypically totally different from planktonic organisms. The take-home message is this: Koch's postulates really can't be fulfilled because it's impossible to duplicate all the variables that are involved in disease expression. Additionally, Koch's postulates do not allow us to readily address naturally occurring environmental, genetic, and other relevant factors that influence disease causation. And they don't allow us to consider the pathogenic complexities induced by sequential or simultaneous infection with polyclonal and polymicrobial biofilm subtypes that we know characterize such infections. I think it has been shown beyond reasonable doubt that endodontic infections are biofilm infections. There are cases where planktonic organisms are growing freely and may mimic Kochian epidemic diseases, but certainly in retreatment cases, we are dealing almost exclusively with biofilm disease. You'll notice in our experiment, even the area that is not stained with the EUB probe, that's the area of the canal that has been covered up with sealer that stuck to the canal and wasn't removed. Underneath that sealer, one would expect to find the remaining biofilm. I think that David and my disagreement really revolves around the status of that biofilm. He might characterize it as dead or the canal as bacteria-free. I would characterize the biofilm as resting, dormant, or in a VBNC condition, viable but not culturable. Proving one or the other is going to be a very difficult scientific problem that is going to take some committed research. The bacterial biofilm life cycles, there's various phases to this, and the key to understanding biofilm disease, in my opinion, is that the resting phase is really one that is very poorly understood. The major key to understanding this is that the biofilm mode of existence has phases, and that in environments that are hostile, the dominant phase is the resting phase. One might characterize a treated tooth even a poorly treated tooth as a hostile environment from a biofilm's perspective, especially given the environment that caused the biofilm to come about in the first place. This resting phase is not like the stationary phase known to microbiologists, as we will endeavor to explain. If you read the extremophile literature, what you see is that the ability to become dormant as a community is a very ancient ability that occurred in bacterial communities, probably or perhaps even at the very dawn of life on Earth. There are estimates that up to 30% of all organic life on this planet isn't even on the surface of the planet. It's buried in rock in the Earth's crust. And when you study some of these organisms, which certainly must be very, very ancient, they have a doubling time of 1,000 years. Clearly, the ability to downrate metabolism and energy expenditure is very old and central to microbial life. So under environmental stress, what do cells in a biofilm do? They reduce their size and volume almost immediately. They reduce their DNA content as much as possible. They reduce their genome sizes. They form blebs and export their DNA. They upregulate genes involved in importing and exporting DNA. Some even become ultra-microbacteria. They can become oligotrophs and live on practically nothing. They reduce mobility, and motility, and they can either increase or decrease cell adhesion. Blebbing may also rid the cell of non-essential DNA, and is a very common finding in the case we did with Rick Schwartz's case. If you notice these TEMs from Rick's case, when microorganisms undergo apoptosis, they almost always bleb, as they also do when they encounter environmental stress.
As Garth Ehrlich pointed out to us in 2010,
up to 30% of some organisms' genome consist of genes only involved in the import or export of DNA, and that the biofilm matrix itself is composed mostly of DNA, extracellular DNA. So commensal bacteria in eukaryotic cells have had 1 billion years to work things out between them. So it's hardly a stretch to conceive of this not only as a bacteria-to-bacteria strategy of survival, but also as a bacteria-to-host strategy to enhance commensalism or hemostasis. Indeed, we are just now starting to understand just how complex this situation is and how this extracellular DNA can moderate host defense in both positive and negative ways. The current thinking is that commensal bacteria and endodontic biofilms are composed of commensal bacteria, are intimately involved in colonization resistance, which is keeping out the bad guys, and modulation of the host response so as to allow for hemostasis. If you can accept that hemostasis or disease tolerance may be the natural end toward which most hosts and microorganisms may trend, then disease is only one of the possible outcomes of an interaction between a biofilm and a host. So infection with a polymicrobial biofilm can result in one of 4 states: commensalism, colonization, latency, or disease. Where David and I probably disagree most is in our understanding of the latency state and what its role is in apical periodontitis. The key concept here is that when host damage is not enough to affect homeostasis, i.e. the damage is minimal, then this state is indistinguishable from commensalism or latency. It is my contention that this state is what we witness in asymptomatic apical periodontitis. And I think Dr. Epstein and Lewis gave us the key to understanding this with their explanation for why 99% of bacteria cannot be cultured. The reason is the vast majority of microorganisms on this earth grow only in polymicrobial communities. And in such communities, they are vulnerable only when they are dividing, and that they therefore use a survival strategy of dividing only when it's safe to do so. They use sophisticated signaling to know when it's safe, and when it's not safe, they go into the VBNC state where they are neither culturable or they appear to be dead. And they can stay in this state for many years and perhaps for many decades. So latent infections and the inability to culture may be expressions of the same survival strategy. It turns out that determining whether a community or an organism is either dead or in the latent state is an extremely difficult thing to do. It is even harder to determine if communities in the viable but not culturable state are even pathogenic. There is some suggestion that it remains to be determined whether cells in the non-culturable state retain pathogenicity. This would go a long way to explaining why asymptomatic areas remain quiescent for years or even a patient's lifetime. So to finish up, a few observations. Number one, the scientific community is just starting to understand the complexity of outcomes possible when multiple infectious agents
occupy a single animal or invade a single site.
And also, the vast majority of microorganisms live only in highly complex communities within which they have intensive interactions. And these organisms in these communities can downregulate their activity and exist in perpetuity as viable but not culturable entities. In this state, they are immune to environmental stressors. And finally, despite these observations, little is known about the factors and processes that influence these communities' assembly or stability. We make a mistake in our inferences if we consider parasitic species in isolation rather than as a community. So to end with a pop quiz, if the claimed objective of our specialty is to prevent or eliminate apical periodontitis, then this case demonstrates why our current disease model is unhelpful in our decision-making process. It provided me with no real guidance or clinical decision-making, although the prior endodontist, believing in our disease model, had absolute certainty that this patient required treatment, and the sooner the better. I like to use sickle cell anemia as an example of a really simple disease and how complex it really can be, even with a simple disease. Sickle cell anemia is the result of a single point mutation on the hemoglobin gene, the substitution of simply one amino acid with another amino acid. And you have to be homozygous for this disease to occur, so the offspring needs to have both parent genes to have the disease. Now, some of these people are very, very profoundly sick, and others aren't sick at all, and some are sick at some times and not at other times. So there's a wide phenotypic expression of this disease. If you outline a disease complexity graph of this disease, you can see it's not so simple. You have the primary molecular mutation, but then there are all the upstream and downstream modifying genes, as well as the intermediate phenotypes, which are functions of the genes unrelated to the primary effect. You also have all the environmental factors which offset disease expression, and they all contribute to a wide distribution of observed pathophenotypes. Now, apical periodontitis must be thousands of times more complex than this simple disease. So when you're confronted, like a case that Sashi posted a couple years ago on TDO, are you sure that our reductionist Cartesian disease model really gives you the guidance and the decision capability of doing the right thing for your patient? When I look at this case, what I see is the smartest thing this patient did was not have the endodontics done. And our disease model informs that decision on every single patient that we have.
Okay, Roger, you're up.
So first of all, this is a very strange experience. It's like you were at a party last night and you're coming down, maybe it's at a hotel and you're at breakfast, and everybody remembers what you did, but you don't. Okay? It's an experience I hope not to have ever again. And it's also interesting because the opening talks were very helpful. You just sat through more than an hour of presentations which were justified by teaching Roger what he needed to know so he could stand up in a minute and talk, which I actually appreciate. It was very educational. So my first thought is, why do you care what the hell the model is? How often does the patient come into your practice and say, before I allow you to do anything in my mouth, we really need to talk about your model? Because I'm really worried about whether those bacteria are viable, whether or not they talk with their friends in deciding whether to wake up, whether or not my x-ray is going to look good or bad in a few years, or 10 years, or 12 years. I don't think any patients other than your colleagues might ask that. And I really do think that what we need to focus on in clinical research is asking questions in a way that when they are answered, helps you make decisions for patients and answer those patients' questions and help them select the therapy that's right for them. And one of the things that struck me about the discussion this morning was the amount of the information that was presented that can be explained away by thought processes that don't help you at all in selecting therapy. So let me let you know one thing that I was thinking. So I would like to propose the Lewis model of endodontic disease. So by the way, as you guys were looking at radiographs which were making points to you, I had a translator next to me saying, that's a bad tooth. The one on the right looks good. The one on the left looks bad. That was very helpful because they just all look the same to me. When I look at a mouth x-ray, what I'm looking for is whether the mandible's fractured. So here's the Lewis model of endodontics. The Lewis are apical periodontists. And as I mispronounce things, please just overlook that. It goes as follows. There is a hidden, unfortunate thing that happens at a tooth for reasons that we have no idea about that disrupt the relationship between the host and everything that usually lives around there. And that upsets the whole community. And as the whole community is upset, sometimes some of the bacteria mistakenly see that as an opportunity to start growing. And when they do that, they sometimes release metabolites or have metabolic activities that destroy surrounding bone. This is the Lewis model. The bacteria are just the result of whatever goes wrong. They don't cause anything. They just happen to be there. So let's think for a second to what extent that might explain things. Well, if whatever this magical Lewis phenomenon is that starts the process is mild, then a few bacteria wake up. But if it's a severe case of Lewisitis, then a lot of bacteria wake up, a lot of them become metabolically very active and cause a lot of bone destruction. Does this explain does this model explain anything in the data that are presented to you? So I'm not going to try to pull someone else's slides up, also that's impolite, although those clips make me seem like a sort of an arrogant you-know-what. Think of the slide that related the survival rate of teeth as a function of the amount of bacteria initially cultured or bacteria cultured at various points during the treatment. If the bacterial count has nothing to do with causality, but is simply a marker for the seriousness or the stage of disease in the Lewisitis or the Lewis model of the disease, you can completely explain those observational findings. My point here is not that I have any idea what's going on. I'm going to suggest to you that you need to just get over yourself and stop worrying about it in the politest and most supportive way possible. And that what you really need to ask yourself is how the hell are you going to move the specialty forward so that when a patient comes in and has a symptomatic problem, you can make a recommendation based on what you know, and we're going to talk about what the word know means. What you know is most likely to result in a good long-term outcome for that patient, and an outcome judged by metrics that that patient actually is likely to care about. So I think that's the way I want to think about it. And couple of ground rules. You can interrupt me at any point, but if you do so, please do it by raising your hand, not by yelling. I would much rather have this be interactive. I am virtually impossible to offend as long as we stay away from my wife and kids. And so you can ask me basically anything. And if this is, this is a long day. I'm an emergency physician. I have the attention span of a mouse. And so the more interactive we can make this, the better. So let's talk about what we know. Yes, sir.
Roger, I think the issue isn't that we need our model to decide what to do on a tooth that is symptomatic. The problem is how does the particular model that you believe in affect your decision making when the patient has pathosis but no symptoms? Then the model is important to us.
I disagree. Okay? Because I think the model has completely confused what you know and you don't know. So that's going to be one of my theses, so we'll see. And I may not get invited back. Okay. So let's talk about knowledge. It is very easy to confuse what you know you would see on a repeat experiment or an observational study versus what you know in terms of causality. And luckily you have literally one of the world's leading experts on causality here, and he will speak later. But you really need to come to grips with the fact that observational studies don't tell you what will happen when you intervene. And all of your questions clinically are in choice of intervention, including whether to intervene, how to intervene. And observational data fundamentally will not get you there, because no matter essentially what observational data you show me, I can come up with an alternative explanation for those data that explain the study. I'm not saying the studies are wrong, that would lead to a different conclusion regarding what you should do interventionally to achieve the best possible outcome for that patient. So for example, we worry when we take care of lacerations in the emergency department of cleaning them out so they don't get infected. Some of them get infected. It's bad when they get infected. It's unpleasant, it requires additional treatment, and it reduces the quality of the cosmetic outcome of the wound. So we don't like them to get infected. So we wash them out. Well, for years we washed them out. We would put sterile gloves on. It made us look very doctor-like. And we would use sterile fluids to wash them out. And we would do all kinds of prepping around the skin with antibacterial stuff, a little iodine here, a little chlorhex there. None of that matters. None of that affects the infection rate at all. We now know that if you irrigate it with tap water with sometimes substantial bacterial counts, that tap water works just as well as sterile fluids. And the prepping around the skin doesn't matter. And the sterile gloves don't matter. It's nice if they're clean. None of that matters. Because the thing that determines the probability of infection has to do with the host bacterial interaction in the devitalized tissue. And essentially, as long as the count is below a threshold, and people talk about 10 to the 4th to 10 to the 5th bacteria per gram of tissue, it just isn't going to get infected. And if it's above that, it is. Okay? And the model that we had, which was we were trying to make the wound sterile, was wrong. And it actually made people do a bunch of things that led to more devitalized tissue. We had to debride, we had to cut stuff up, we did all kinds of mucking around, which actually increased, in some cases, the rate of infection. So but I will finish my sentences, or my thoughts. So the point was, we had a model We followed it. It made sense. It could create correlations, things that were likely to have higher bacterial counts, like dog bites did tend to get infected more. Cats are horrible. Humans are worse in many ways. And yet, in terms of telling us what we needed to do, it misled us. Yes, sir?
You found out that you didn't have to use all these sterile devices. Did you find that out with an experiment?
Yes.
So you had to have a hypothesis that it didn't matter, and you had to go through an experiment to show that that hypothesis was correct.
Absolutely.
So isn't that the point here, that we've seen some hypotheses without the experiments?
That's part of the point. Yes. We'll go. I have hours, so I can get to it. Okay. All right. Yes. Now I have less time. I did.
Then the second experiment that showed it wasn't important to use sterile gloves, that experiment, I'm sure, could be shredded to pieces as a unit itself.
Well, the experiment that was done that showed that the sterility of the gloves didn't matter had to be done in very large sample sizes. It had to be done by multiple people in multiple places to demonstrate that it was a generalizable finding that was not specific to a particular type of wound or a particular location. There's a lot of things that have to do with the generalizability of results. And my point was not so much a distinction or a comment about that particular line of reasoning. The point was that one needed experimental interventional data in order to change the paradigm and to create knowledge that helps inform our treatment choice. And one of my fundamental concerns regarding your literature and regarding, frankly, much of the information that was presented this morning is that it confuses correlation with causality. And that worries me very much, because the place where that gets us into trouble is when we assume influencing the factor found to be correlated with the disease will impact outcome, when in fact we're messing with something that's a downstream effect. So if the Lewis model of endodontic disease is correct, and there's a fundamental process at the beginning that triggers it, and the bacteria are just the result as opposed to the cause, then reducing the bacterial count may fool you by making the disease sort of revert to an earlier stage without actually fundamentally changing the course. And we're worried about long-term outcomes here, right? We want the tooth to be functional and pain-free and cosmetically acceptable 10, 15, 20 years from now. And that's, I assume, what we do agree that's what we care about, right? Okay, or I'm in the wrong place. Okay. So that's what I want to function on. So let's come back to that. Let me give you an example. Let's talk about the early days of the treatment of patients with what may not have been known at the time, but was HIV-related disease with pneumocystis pneumonia. So if you look at those patients, young, previously healthy men in the area where I was trained, and they would come in with respiratory distress, and you would find the pneumocystis organisms in the lung. When they were sick, they had pneumocystis in the lung. When they weren't sick, you didn't have pneumocystis in the lung. And if you treated those patients with agents effective against pneumocystis, they got better temporarily, okay? And then they all died. That was the late 80s, early 90s in the San Francisco Bay Area, okay? So the common endpoint, and by the way, we're all going to die, but they died early. The model missed the fact very early on that the pneumocystis wasn't the problem. We all have pneumocystis. We're exposed to it all the time. The problem was an otherwise unidentified agent that was changing the host in a way that the pneumocystis manifested itself. And if you think about HIV disease as a broader topic, it's manifested by all kinds of different opportunistic infections. That word polymicrobial that was mentioned, this is sort of a hallmark for maybe we don't really understand what the fundamental first thing is. And if we're going to achieve long-term good outcomes as a general strategy across many diseases, may or may not hold in endodontics, but as a general rule, if you can identify the root cause of the illness and fundamentally change it, that's the way to achieve long-term outcomes. So let's talk a little bit about how we might think about how we can move the field forward. And I want to move you away from this preoccupation bordering on obsession with your model, because your model is not going to help you. Okay? I think the model has been taken as far as it's going to get, and so let's get past it. I'm a practicing emergency physician. I'm the chair of emergency medicine in the Department of Emergency Medicine at Harbor UCLA, which is a county trauma center. I see patients, I supervise residents, I go in on nights and weekends. I love what I do. I would characterize my specialty as making critically important decisions with completely inadequate information. But I'm practicing a setting where you don't have the luxury of making a decision later. You have to make a decision now. Because of that, this specialty causes us to think a lot about uncertainty. How do you make decisions in the setting of uncertainty? What kind of knowledge helps inform clinical decision making? And I think it provides a useful perspective for discussions such as we're having today. In terms of disclosures, I know nothing about endodontics. I have no interest, financial or scientific, in endodontics, dental care, or oral health. I do receive funding from a wide variety of both public and private entities related to clinical trial design. So when I talk about clinical trial design, that's an area in which I have a lot of interest, intellectual and otherwise. And there are pockets of shameless self-promotion embedded within this presentation. That was the warning. Okay. So the goal here is to try to motivate you to do the incredibly hard work of reframing your questions, reframing your discussions, and doing endodontic research that will allow you to gain the information necessary to select treatments for patients that are most likely to result in benefit, by which I mean good long-term outcomes, and to have the information necessary to recognize when different treatments are better for different patients. So there's a matching of the treatment selection to the patient. To understand and to do the research that helps you understand where you have gaps in your knowledge. I don't think you have gaps in your knowledge about what bacteria live in that little canal. I just don't think it matters. Okay? And this is a prioritized list, by the way. And the third is to help you do research that helps you understand what research needs to be done to help you with 1 and 2. Okay? And if you really think about it, 2 is there to help you learn about what you should do to answer 1. Everything comes back to treatment selection. So I want to talk a little bit about key opinion leaders. So do you guys use this term key opinion leaders in your specialty? Right? And every commercial entity is trying to find the key opinion leaders because you get them talking about your product and you'll have more market share. You wouldn't do that, right? Okay. So where do they get their opinions? Okay, what makes someone a key opinion leader? Is it does God herself, just seeing if you're listening, come down and anoint you, say, you're going to be a key opinion leader, and suddenly you have a bunch of opinions? Or do key opinion leaders gain that role within an academic or intellectual community by the strength of their logic or their knowledge or their ability to change their opinions in response to new information? Well, I have to tell you that my experience working across a variety of intellectual disciplines is that many key opinion leaders seem to have started with the opinion, and then the publications follow the opinion. Now, some of that is necessary and good in that unless you're very passionately attached to an idea, it's hard to get yourself to do all the work necessary to do good science. But one of the things you should be looking for in your key opinion leaders is the fact that their opinions change in response to data. And data may be large sets of data, or they may be isolated examples of cases that are so contrary to the way you think about your disease that they force you to rethink what you believe to be true or what you know. So, for example, it's often been said that you can't change medical science with a single case report. Well, it depends what that case report is. The first case report of a cure of HIV, that changes the way we think about the disease. The one that I used to use as an example was rabies. There had been no patient who had survived after becoming symptomatic with rabies in the absence of partial vaccination. Very specific clinical case, okay? And then there was the first case where a young girl had not been vaccinated but was exposed, developed symptoms and was treated, and survived. That completely changed our thinking about that disease. So small data sets, including of teeth, should cause us to rethink what we know about a disease, and our key opinion leaders should be open to thinking of things. So there is a wonderful, if you haven't read it, you really should pick it up. There's a wonderful thing in the British Medical Journal that's called Alternatives to Evidence-Based Medicine. And it talks about various things. There's vehemence-based medicine. The stronger you believe in something, the more likely it is to be true. There's nihilistic-based medicine, which is you don't believe anything works, so you just let nature take its course. And there's this thing which I like, and as the older I get, the more I believe in, which is eminence-based medicine, that we have these senior colleagues that have this faith in their clinical experience, but unfortunately clinical experience is defined as doing the same thing, making the same mistakes over and over again with increasing confidence, okay? And one of the things that we should always be on the lookout for, because it is important for the outcomes of our patients, is be on the lookout for eminence-based beliefs within your specialty, and make sure that you pay attention to the key opinion leaders whose opinions change as the actual evidence changes. Now, how many people have seen this internet thing? Anybody think they know where I'm going with this? No, okay, good. So the top is a relatively simple depiction of a very simple organism. The bottom is a ever so slightly more realistic depiction of a more complex organism. But what I want to do is I want to change it. The top is the way we have theories about disease. We've had these wonderful theories. You know, the anthrax bacteria causes anthrax, no anthrax bacteria, no anthrax. That actually works. It just happens to be a really simple causal mechanism in that disease, okay? The number of diseases that are incredibly simple with single therapies and clear cause and effect that we don't understand yet is small. You know, we got the simple diseases worked out. The diseases we struggle with are the complicated ones, the ones that tend to look more like the reality. And if we continue to believe that the top disease model is going to guide our therapy when in fact what's complex is actually going on, we will continue to make mistakes in the way we ask questions, the way we do research, and the way we recommend therapies. So let me give you a couple of examples of that. This is one of my favorites. It's from the late 80s. Military anti-shock trousers, so-called mass pants. How many people remember these? If you watch old World War II movies, or especially the Korean War, people wore them to, they called them G-suits, because they actually do help you not pass out if you're doing you're in a high G maneuver in an airplane. But people notice that when people are shot and are bleeding to death, which is something I do have a substantial amount of clinical experience with, as people die, they die from blood loss, their blood pressure goes down, and often they become confused as they go into so-called shock. Okay? It's a horrible thing to see. And the thought was that if you put these mass trousers on, they squeeze the legs and the lower pelvis, that you squeeze the blood out of those parts of the body, and you get a so-called autotransfusion where your own blood is returned to the central circulation, and this will help you survive longer after being shot. Not only was the theory pretty internally consistent, But in fact, there was a whole bunch of data, including prospective and data, not really randomized, that supported it. Because as people were dying and they became confused and their blood pressure was going down, if you put these things on and you pumped them up, and I remember doing this as a resident, and it was a big job to be the person pumping up the mask suits, the blood pressure would come up and the person confusion would go away. They would look less sick. So these things were deployed. It was a requirement in most licensing agencies that these things be deployed across ambulances in both military and pre-hospital settings. In Los Angeles County, where I work, every ambulance by law had to have mask trousers in them. That was the law. So when you don't have science, go with regulation. Okay? Okay. What was the problem with this? Well, some people who had hypotheses and started to do experiments noticed that if you put little piggy mask trousers on volunteer swine in laboratory experiments, that if you put the mask trousers on after some very carefully induced injuries that tried to reproduce penetrating trauma in the chest, even though the mask trousers raised the blood pressure, the pigs died more. It was so inconvenient because these things were all over the country, okay? And the people who started publishing these things had trouble publishing them in the best journals because everybody knew and had experience with cases where they put on the mask trousers and the person's blood pressure came up and they woke up, okay? And there was a group that identified that the issue was that as you raise that blood pressure, because there was an uncontrolled vascular leak that hadn't been repaired surgically, the rate of blood loss internally actually went up. And the fundamental thing that was killing you was not the low blood pressure, it was the bleeding to death. Okay? My point here is that what you see clinically as improvement may not be improvement that's tied to long-term outcome. So a very courageous group in Houston did the following study. Houston has an active knife and gun club, and they have a lot of what they call penetrating truncal trauma, so basically gunshot wounds and stab wounds to the chest and the abdomen. And if the paramedics went out there and the person's blood pressure was low, so they were in shock, then they randomized, sort of, they did it by every other day, I believe, whether or not they used the mask trousers or not. And the people who got up on stages like this and said this was unethical, this was inhumane, they were killing people, was really tremendous. The people who were doing this were vilified in some surgical meetings. Being surgeons, some of them didn't care that they were being vilified, okay, but it was really nasty and it was personal. Okay, it took on a very personal tone. The problem was that they did see a difference. It was just in the opposite direction. More people died. It wasn't just that the mask trousers didn't help. They had an excess of mortality in the patients getting the mask trousers. And it was true whether you looked at the subgroups of the abdominal trauma, the penetrating trauma, the chest trauma, the cardiac injuries. It was clear that the mask trousers either did nothing if you had just an extremity injury, which shouldn't have been in the trial anyway, and they killed you if you had one of these truly life-threatening things, okay? And then this led to the removal of this across all the ambulances in the United States, took them out of the military, took them out of our ED, and changed practice really almost overnight. I think it was about 6 months that people, tried to look at the data and try to figure out if it was faked, and then people kind of realized that, oh my God, we've been killing people with this practice recommendation for years and years. And the number needed to kill associated with this was about 1 in 20. That's a really, if you do an intervention that actively kills 1 in 20 people you're treating for years and don't figure it out, it tells you how powerful our models and our preconceived notions are at blinding us to what's really going on. And I think that's a very, very important lesson here. Yes, sir.
You said it was 1 in 20, but for a clinician or an emergency room physician like you, that would be hard to notice, I would think.
Yeah, but penetrating trauma is one of the most carefully studied and tracked things. All the trauma centers have to collect outcome data. I think probably the way this blinded people is they didn't even look. You know, it was like, we know they help. I've seen people wake up with them, and you're blinded by that knowledge, in quotes, and so you don't even look. But you're right, 1 in 20 is hard to pick up. But there aren't many treatments that save 1 in 20 people or kill 1 in 20 people. That's a big treatment effect. Okay. So let's talk a little bit about septic shock. This is another thing that illustrates this logical issue. So back in the 1970s, septic shock, severe sepsis and septic shock was characterized as an infectious disease state in which the body's own immune response was so out of control, overblown, dysregulated, that the immune response was in fact causing additional damage to the host. How many of you were taught this? Okay, doesn't come up much. Yeah, if it happens in dentistry, I guess that's really bad. Okay. Although the picture of the girl, by the way, with the facial infection, that's my experience with dentistry, just so you know. That's what I see all the time. Okay. So if it was an out-of-control immune system that was killing you, well, let's do something to taper down the immune system. So people tried over and over again things that would thought to downregulate the immune system, like steroids and anti-inflammatory doses, anti-tumor necrosis factor agents, activated protein C. Each one of these targeted one or a few parts in the inflammatory cascade. And there's hundreds of papers like this. There were a few false positive results, including one that caused FDA approval of a drug that they then had to rescind. But right now, there is no FDA indication for treatment of this disease. Okay? That means no successful therapies over 35, 45 years of work. Unmitigated failure. Okay? And this is an area that I'm actively involved in, and there are people working on it. But let's talk about why it's failed. It's because this is a highly oversimplified part of what we currently think we might know about the disease process. Okay? How the hell are you going to come up with a therapy to affect outcome when this is just a glimpse of what's going on? The point here is the model only helps you get so far in selecting therapies or predicting outcomes. At some point, you just got to do the experiment. So the challenge to you as a specialty is how do you get yourself organized to do the right experiments that give you the answers you need? Okay. So possible paths forward. Questions to there? And my most important question, when do you want that break? 10:15. Okay. So possible paths forward. There's a tremendous interest and love of observational data. And observational data can take many forms, but essentially the idea is you take advantage of natural variation in your patient population, disease, bacterial counts, whatever it is, and you look at correlations between the thing that's varying naturally and the outcome of interest, which also varies naturally, and you observe those correlations. What you do next is critically important. If all you do is you say, there are correlations, you're fine. And if you say, I know there are correlations, that's fine too. What you have to guard yourself against saying is that if I now change the first thing, the second is going to change. That you don't know at all. Okay? You may suspect it, you may hope for it, you may pray for it, but you do not know it. So these observational data may take the form of cross-sectional or longitudinal observational studies. I was looking through your literature for randomized trials I could use as an example. I had a very hard time. But I had a very easy time finding people who followed teeth with various degrees of fidelity over time, okay, and then drew correlations and then made them sound like they were causality. If you use this capping agent, you know, you're going to have this rate. If you use that capping agent, I don't even know what I'm saying, then you're going to have a different survival rate, and absolutely nothing about why the practitioner chose one capping agent over another. Like you guys you just flip a coin. Today it's MTA. I don't know what MTA stands for. So today it's MTA, tomorrow it's something else. You don't do that. You choose things, or practitioners at a different stage of training and career have systematic differences in how they make choices. So I have no idea how to interpret that observational literature. Another thing that I'm going to spend a little bit of time on is the fact that electronic health records in medicine, and I assume in dentistry and endodontics, are creating the potential to assemble extraordinarily large, rich data sets in which we have information on patient characteristics, treatments that were selected, past tense, and the outcomes that the patients have over time if they choose to come back to practices that share software or share data. And there is a part of the medical research community that is hoping that by mining and analyzing in a very sophisticated way these large data sets, we can unravel cause and effect and unravel confounding and the things that influence the treatment selection and figure out what would work in an interventional study to improve outcome. I have grave concerns about that. Dr. Greenland hopefully will talk about that as well, or at least tell you if he thinks I'm stupid. Okay. So there's this whole set of observational data that you seem to be enamored of in your specialty that I have grave concerns about. And the alternative is to actually try things and the selection of what you try should be informed by the models that you have, or the uncertainty you have in those models, and actually see what happens and do randomized control trials. And I think that if you don't change your mode of doing research to doing randomized trials with good long-term follow-up, that you could invite me back in 5 years, and like our esteemed host, I could just play a tape of my talk this time, and it would still apply. I think you're going to have to do that to break out of this mold. Okay. So I actually did pull some literature. So let's look at this study. A long-term survival of endodontically treated teeth at a public dental specialist clinic. This is a recent publication. How many of you, is this something you all have seen and read? Okay. So what struck me about it? So this is a retrospective study. So by definition, there was no control over what was done. There couldn't be any randomization. So the variation in the characteristics of the patients and the treatments are just what happens in routine practice. There were 15,000 examined teeth, and 420 were selected. There's more teeth than there are patients, so some of the teeth share characteristics with each other. They share their home, okay? And they were randomly selected. They used a Kaplan-Meier estimate for the survival of the teeth. And by the way, nothing would make me happier if at the end of the day we just talk about statistics. It may not make you happy, but if anybody wants to talk about statistical methods or has questions, I'm happy to try to answer them. But a Kaplan-Meier estimate is nice because as patients are lost to follow-up, it does a pretty good job of at least keeping straight the denominator that's changing over time and calculating the probability of success. It does not address the fact that people are lost to follow-up for a reason. I don't go back to your clinic because my tooth fell out and I don't like you, okay? And that obviously creates a bias in the estimate associated with patients being lost to follow-up, okay? And then they start to make comments about what they think this means, although that isn't quite worded that way. So what it says here is placement of a crown has an adjusted hazard ratio of 0.27, and there's a very small p-value, which is supposed to impress you, and an age-adjusted hazard ratio of this with a small p-value were significantly independent predictors for survival rate. So this is a hazard of tooth loss, so a low hazard ratio is a better survival rate for the tooth. And the idea is that this predictor influences the survival. But you have no idea why this particular intervention, placement of a crown, occurred in some teeth and not, well, I'm sorry, I have no idea. But if I'm going to ask somebody in the back who's not paying attention, okay, Why would one patient get a crown and other patients not get a crown? Oh, and I will pick out somebody if no one volunteers. Money? Okay. So if I have poor dentition and no money, I'm less likely to get a crown.
This is a public dental clinic in Denmark. It's basically free.
Okay.
So I don't agree with that point.
Okay. I have noticed a little bit of a pattern that maybe you don't agree. Okay. Okay. How about the bit about dentition? Does the adjacent dentition affect whether or not someone will put a crown on?
Yes, or remaining tooth structure. How much tooth is remains before when you finish your root canal?
So if there's more tooth, it's easier to put a crown on? Okay, and if there's less tooth, you're less likely to get a crown. No, I just need a few that I don't get vilified for. Okay, so, and I'm sorry, the symptomatic would go which way? More symptoms, more likely to get a crown? Okay, so that one goes the wrong direction for me. Okay.
For getting the root canal in the first place may have been pain, and that's not there anymore.
Then
they may not come back.
Exactly.
Less remaining tooth.
Okay, so let me go. I'm going to go with that one because this is spiraling out of control for me. So I'm going to assume that in the stage of disease, the farther along the disease is, it's more likely to be symptomatic. Are we okay with that? I'm also going to assume that the farther along the disease goes, the harder it is to have the tooth survive ultimately. Just the farther the process is, the harder it is. So the more likely that you're symptomatic, see if this works, the less likely you are to get a crown because once you you take care of the acute infection, the symptoms go away. So you don't need a crown, so maybe the people who didn't get the crowns had more advanced disease than people who didn't need it, who got a crown. I'm just making it up. People with more advanced other dental disease are less likely to get a crown, but the fact that there's more dental disease elsewhere in the mouth tells you something about the environment in which that treated tooth lives, right? I'm sure that the outcomes of teeth are correlated within a mouth, positively correlated, okay? So now I can explain this observational hazard ratio in ways that has nothing to do with a true effect of putting a crown. Now, I don't know if a crown helps. Maybe it helps, but this doesn't tell me whether it helps. Okay? So this doesn't help me make a decision regarding regarding placing a crown, or if the patient asks me, "Wow, doc, do I need a crown?" I can't answer the question. I can say, in a large study in Denmark, patients who got crowns, their teeth lasted longer. And it sounds like I'm answering their question. I'm just not. I'm just bullshitting. Okay? And we really have to be honest with ourselves about when we know something and when we're just using that term I shouldn't have used in public. Okay. What about the statistical methods? They did something called stepwise variable selection. And Sander, I hope you agree with me that this is horrible. Okay. Stepwise variable selection is when you're doing a multivariable model, you're trying to figure out what things predict the outcome you care about, and you try every one, and you keep the ones one at a time that are most predictive. And at the end, you write something that sounds like, in our multivariable model, we found factor X, Y, and Z predicted the outcome. Okay, so those are the important things, and the implication is nothing else is important. That's the way it reads to a clinician. It just turns out that if you do the same study in a different set of patients but ask the same questions and go through the same thing, the chances that those three variables, X, Y, and Z, survive each time is incredibly low. It's just a fluke. So the reliability, meaning the degree with which you get the same answer each time, in variable selection, meaning you identify what's important, is horrible with stepwise variable selection. So this is a methodologic detail buried in the statistics that completely, in my mind, invalidates their conclusion about what predicts the outcome. Because I have no faith that if they did the same study again in another public health clinic in Denmark, that they'd end up with the same predictors, because I know it is a demonstrated fact that this statistical method, albeit popular and it's just one button, okay, the whole point about this SPSS software, you can do stuff and have no idea what you're doing. Even though it's popular and easy, it's just not reliable. Okay. What else about this study causes me some concern? Well, we started with an original database of 15,000 patients, some of whom had multiple teeth treated. Somehow, we ended up with 8902. I honestly didn't understand that. Maybe it's buried in it. I didn't have time to reread it multiple times. Then they randomly selected 569. So if you believe that first step was random, you're okay. And then if you believe where they said randomly selected, it's random, that's okay-ish. But then suddenly out of those 569, they exclude 239 patients, meaning you know nothing about what happened to those patients and those teeth. Well, they did it if they only had one examination. Okay? Well, that can be a marker for all kinds of things. It can be a marker for good things. Their symptoms went away. They were going to be fine. It can be a marker for they didn't like you. It can be a marker for all sorts of things. Declined treatment. They decided that they needed tooth extraction. So we have no idea. And then there's 330 patients with 420 teeth for which we have the data that are reported here. The important point is that there is no reason to believe that the outcomes in those 239 patients who were excluded are going to be similar, or at least not systematically different from the outcomes in the 330 that we reported. And 239 is such a large number that you could get a qualitatively different result if you had had the complete set of patients to follow. Yes, sir?
I actually know this study. So that 239 is patients that didn't receive any treatment, so there's nothing to follow up on. It's not that they're excluded. It's that they chose that 569 randomly, and then from that 569, those 239 didn't get any type of treatment. That's why it says only examination, declined treatment, tooth deemed for extraction. So that's what happened to them. So then out of those, that 350 patients got treatment, and those are the ones they followed up with.
Okay, so let's talk about the 55 who declined treatment. Does that mean they're different or similar? Do we know? I'm rarely going to let you win an argument, but you did pretty well there. Okay. So do you think the 55 who declined treatment were similar or different than the 330 who got treatment? I don't know either. So obviously I know far less about this study than you do, but the point, and you have taken a little bit of the wind out of the sails, but the point is that you just are missing people, and you don't know, and you're missing them in a way that's non-random, and you're going to be drawing a conclusion about what you should have recommended to everybody based on what happened to a subset, and that's fundamentally dangerous. There was a question in the back here.
Kind of similar to his, it seems like what they excluded is actually tend to add to the validity because they're trying to make people who you would be drawing from equivalent groups, whereas you're using that box to the right to say this made it worse. And it seems to me that's actually making it a more legitimate study.
Okay, so I think this is sort of a different perspective. So if, for example, these were exclusion criteria, let's ignore well, actually we can probably include the decline treatment also. You could have at the beginning of, say this was a prospective study. Part of the problem is it's just not a prospective study. If it was a prospective study and you said our inclusion criteria was they needed treatment, so they weren't examination-only patients, and they were willing to consent to the study, so that gets rid of the decline treatment, and the teeth didn't meet some pre-specified requirement for needing extraction as opposed to endodontic treatment, then I can sort of see how you can define prospectively a population about which you can form a clear hypothesis. So this is killing me because the point I want to make is right, but the example I chose apparently was not a good choice. Okay, so I'm just going to move on in a second and try to forget this. Go on.
So part of the outcome of the group that actually got treatment is a function of the extract treat decision. So you can have 110% success if you want by only treating cases with a very high prognosis. And since we don't know what the decision criteria was for deemed for extraction versus recommended for treatment, we really don't know what those cases look like. They all could have been violent cases.
Yeah, so I think you're correct. The point is that you don't know exactly how the decisions were made that put people into the excluded category. I think it's a slightly different question. I think the point you're making is that it's a little hard to apply exactly the criteria that identified their study population in your own work. The point I was trying to make is that in observational studies that patients are often excluded, that you don't know why they're excluded, and it can potentially bias the correlations you see, even before we get to the point that correlation is not causality. So I'm going to, I will look for a better example if I'm invited back. Okay. Okay. So the next one I'd like to do, and then after this we're going to take our break, is a comparison success of implants versus endodontically treated teeth. So this was a study in 2008. Is this a study that you guys are aware of? Is this something new? Okay. Okay. So in this study, they used a determination of the outcome based on clinical chart notes and radiographs, and failure was defined as removal of the implant or tooth. So this is a retrospective chart review study, and you know what happens to the patients who choose to come back to this practice setting and have their tooth extracted. Implants were placed by periodontists in a group practice, whereas the endodontic treatments were performed by endodontists. That wasn't obvious that people do what they should do and stay away from each other's specialty. I didn't know what there was. There some point there?
It could always be dental students. Also placed implants, endodontists, some endodontists placed.
Okay, so this is to assure us that there was an appropriate level of technical expertise in both groups? Okay, all right, that's helpful. Okay, see, we're learning this together. And then they say the success of implant and endodontically treated teeth was essentially identical, but the implants required more post-operative treatment to maintain them. Okay? And then they provide some graphs. These are the worst graphs ever. Where they give you the percent that are successes, that were uncertain in terms of whether they were successes, or that were successes with a more stringent criteria for successes. Apparently, it's necessary to put the numbers on the vertical axis in the legend and to the right. And you sort of see things look the same. Okay? And then they have this graph, which you guys probably like, which is that the implants require a lot of more post-operative care than the endodontic work. Again, you have to have two in a number of different places. Okay. How do you interpret these data? So I have no idea. I have no idea why patients chose an implant or chose endodontic treatment. I just have no idea. So I don't know if there was some sort of self-selection. For example, I don't know whether one of these, in one of these cases, patients were told, your tooth looks pretty good, let's do a root canal. Someone else, wow, your tooth looks pretty bad, a root canal certainly wouldn't work, we're going to have to go with an implant. If that was the process, I have no idea if that's plausible, then the implant arm is getting patients with a much later stage of disease. And the fact that the implant arm looks as good as root canal suggests it's actually a better approach. Okay? So is that the thought process? How would a general dentist who sees a tooth that's in bad shape decide whether to refer me to an endodontist or to an implant? Is it kickbacks? What determines it? Okay.
So I think the motivation for the study is that if a dentist sees the same tooth, same degree of disease, they have been choosing implants in our specialty fields based on the belief that implants are more successful. And that's what they tell their patients, and the patients accept their advice. So this, I think the motivation for the study was to evaluate, I'm going to not say demonstrate, I'll say evaluate whether that hypothesis was true. And what the result was is that under equal circumstances, a natural tooth is, or root canal treatment is as successful.
So I believe that is the message. I think it's totally unsupported by these data. Okay, so let's suppose someone, how often do you see an advertisement where even though the language is technically correct, you know it's misleading? Okay, we will beat any price at this dealer. What they mean is you have to get it in writing, you have to have some guarantee, and they'll beat it by 1 penny, but not actually sell you the same car. I mean, how often do you see something where it's carefully worded to be correct, but you know people will misinterpret it? And saying that Donald Trump is not going to make us great again? I am not jumping at that. Okay. So scientific publications, I got you, so 1 second. So scientific publications should never be written in a way so that the intelligent, thoughtful clinician draws the wrong conclusion, because that is immoral. Okay? This suggests that given the same tooth, your language, in equivalent circumstances, the survival rate would be similar. There is absolutely no reason to believe that the teeth were the same in the two groups. Okay? There is some reason hidden from you, just like the details of the car salesman's negotiations, why people were recommended for one versus another. This is really, really bad, because it can force people to draw a conclusion that it doesn't matter what you recommend. And I don't know if that's true, but I know this doesn't prove it. You're going to get the last question, then we'll take a break.
On the last slide, when it says that all of the implants were placed by periodontists don't do endo. So if they see a tooth that's questionable, in my community, I place implants. So in my community, if the referral gets to the periodontist first, virtually 100% of the time, oh, this needs an implant. So when it goes to an endodontist that is at least, studied or versed in the two different options, they can give the patient a better suggestion. So on this article, from what I just saw, if they end up in the periodontist office, they're going to be the ones that, yeah, you need an implant, even if they don't.
Right. So the question is, what determined who saw them first? And I have no way of knowing. So we're going to come back with the solution to this after the break. Thank you very much.